Dr. Rashni, I think we can start now.
Just give me a few minutes, ma'am. There is a fire alarm going on. Just one
Okay.
minute.
Okay, take your
It
time.
might, yeah. A very good evening to all the respected dignitaries, our distinguished speaker, and my dear colleagues. On behalf of the IHMA National Women's Wing, I, Dr. Rashni Vijay, with over 18 years of clinical practice, currently working as a senior homeopathic consultant at Calcium Clinic, Dubai, take immense pleasure in welcoming you all to the Women and Child Health webinar series. Before we proceed, I would like to take a moment to extend special appreciation to Dr. Jagati, convener of IHMA National Women's Wing, whose tireless efforts have ensured the smooth functioning of our webinar series. From coordinating the Zoom sessions and managing recordings to handling technical glitches and uploading the sessions on YouTube. For those who couldn't attend live, your dedication truly keeps everything running seamlessly. Thank you, Dr. Jagati, for your consistent commitment behind the scenes. A heartfelt word of appreciation also goes to Dr. Halloween Coelho, chairperson of the IHMA National Women's Wing and one of the senior most practitioners in the UAE, for her constant support, active participation, and encouragement to all of us. Thank you so much, ma'am, for the person you are. Also, a word of appreciation to the organizing committee of the IHMA National Women's Wing for their continuous efforts and teamwork in making this webinar series such a success. After the very informative session last week by Dr. Shalini on a bird's eye view on neurodevelopmental disorders, we are all eagerly looking forward to today's presentation on ADHD, understanding its neurobiology and homeopathic management. Now, I have the pleasure of inviting Dr. Dhanya Nair to deliver the welcome address. Dr. Dhanya has completed her MD in homeopathic practice of medicine and also holds a postgraduate diploma in emergency medical services. She is a dedicated homeopathic practitioner with over 5 years of clinical experience in India and is currently preparing for her MOH examination here in the UAE. Dr. Dhanya, over to you.
Thank you, Dr. Rashni. Good evening, doctors. I hope you all had your evening tea or coffee because we are going to talk about a topic that definitely requires some focus and attention. Yes, ADHD. So if your mind wanders a little during the session, then don't worry. You'll be perfectly in theme. I, Dr. Dhanya Nair, on behalf of IHMA National Women's Wing, welcome you all to today's session of Women and Child Health webinar series. It's truly wonderful to see such enthusiasm and interest this evening as we come together to explore an important and insightful topic, ADHD, understanding its neurobiology and homeopathic management. ADHD, attention deficit hyperactivity disorder, is a common neurodevelopmental disorder affecting millions of children and adults worldwide. ADHD affects not just the concentration and behavior, but the entire learning and emotional journey of an individual, as ADHD is deeply rooted in the way of the development the brain develops and functions. Today, we'll explore the fascinating neural mechanism that underlie this condition, from the roles of various areas and pathways of brain that regulates attention and executive control. It doesn't end with just a scientific and neurobiological perspective, but dives through the holistic lens of homeopathy, which focuses on restoring balance and harmony within the individual. As the saying goes, doubts are a sign of active learning. and the insightful queries from our last webinar showed us how engaged everyone was, or I would say how engaged Dr. Shalini kept us. We sincerely appreciate our guest speaker's effort and patience in addressing each question through the WhatsApp group. Over to you, Dr. Rashmi.
Thank you, Dr. Danya, for such a warm and gracious welcome and also briefing upon the topic. Now, I would like to invite Dr. Amarjit Kaur to introduce our speaker for the day. Dr. Amarjit is a graduate from Bangalore University and has previously served as a faculty member at Lord Mahavir Medical College, Ludhiana. In the UAE, she established her own medical facility in Sharjah in 2017, and in addition, she also runs a business specializing in 3D printed products. Dr. Amarjit is well known for her active networking and dedicated efforts to promote homeopathy across various platforms. Over to you, Dr. Amarjit.
Thank you, Dr. Rashmi, for that beautiful introduction. We all know Dr. Shalini. Last time's webinar was so insightful, but of course, a reintroduction is due. So Dr. Shalini is the founder and chief consultant of Dr. Shalini's Homeopathic Clinic, Tiruchirappalli. I hope I pronounced that right. So Dr. Shalini is an experienced homeopathic physician with over 18 years of clinical practice, a graduate of the Government Homeopathic Medical College, Thiruvananthapuram. She also holds a PG diploma in homeopathy in hospital management and an MBA in HR. As founder and chief consultant of her clinic in Tiruchirappalli, she offers holistic patient-focused care and was recognized as the best homeopathic practitioner in Tiruchirappalli. She co-authored Reverse Repertory of the Mind and contributes regularly to the IHMA Homeopathic Journal and her educational YouTube channel. A passionate advocate and speaker, Dr. Shalini strives to make homeopathy more accessible and scientifically understood. Welcome, Dr. Shalini, once again on behalf of all the doctors here.
Thank you, Dr. Amarjit. I kindly request all participants to please write down your queries in the chat box. They will be addressed during the question and answer session at the end of today's presentation. Now, I would like to invite our esteemed speaker, Dr. Shalini, to take over the session. Over to you, ma'am.
Thank you so much, Dr. Rashmi. Thank you so much, Dr. Danya. And thank you so much, Dr. Kaur. I believe I'm not able to read your name. I'm sorry. And I would like to take this opportunity to thank Dr. Halavan ma'am also for inviting me. Thank you for providing this platform where I'm able to share and learn equally about my journey into neurodevelopmental disorder. And I would like to make a special mention for Dr. Rekha ma'am also, because she was the one who introduced me into this area of expertise of homeopathy. So we shall start the presentation. Since I have not checked, let me see where sharing is having proper. Is my audio clear, Dr. Rashmi?
Yes, ma'am, it's
Yeah.
clear. Yes,
So,
audible.
okay, so now I'm going to share the presentation. Is this clear so far?
Yes.
Okay.
Yeah, now we can see and we will
Just a second.
Slide sharing more.
Yes.
Just wait 2 seconds. Is it fine?
Yes.
Yeah?
Yes.
Clear?
Yes. Yes, ma'am.
Okay, done. So we shall start. So we know the topic. It's actually, if you see in social media and everywhere, it's quite rampant. Everybody is talking about attention hyperactivity disorder. Every child you meet, they have been diagnosed as attention hyperactivity disorder. Even adults are like, if you just scroll through the social media, any distraction, any impulsivity, everything they'll say they are having attention hyperactivity disorder. So to understand that, the core is unless and until if it has not been diagnosed, it's not actually ADHD. It's the symptoms quite overlap with a lot of our day-to-day social media and right now what is happening in today's world. So like we say doom scrolling and all, so these things and all overlap with ADHD, so they self-diagnose. So to understand what ADHD is, we are just going to go into the neurobiological aspect. I have also covered various other aspects also, so let's go into it. I hope you'll all have a wonderful session. So before we start, we should always pay our obeisance to our God in aspect of homeopathy, Dr. Samuel Hahnemann. So what I'm going to start, we'll be having introduction. We'll be discussing about the neurobiology, the core features of ADHD, the classification, the diagnostic criteria, actually both overlaps, but still, standardized assessment tools, differential diagnosis, homeopathic management, few additional points, and case studies only if the time permits. So introduction to ADHD. We know what ADHD is from the prior session also. It's basically a neurodevelopmental disorder, which is characterized by persistent pattern of inattention and or hyperactivity, impulsivity, emotional dysregulation that are excessive and pervasive. Pervasive means all through. Okay, and impairing in multiple contexts and developmentally inappropriate. Having impulsivity, having hyperactivity, having more of curiosity is okay, but everything is age dependent. So when that is developmentally inappropriate, we start to think about it. It represents a deficit in the brain's executive control system, affecting the ability to regulate the attention, behavior, and emotions appropriate to age and context. Always remember, ADHD is the main factor is age and content with respect to neurodevelopmental disorder. So this is DSM-5 based upon American Psychiatric Association 2013. What their pointers they have mentioned is, it's ADHD is a neurodevelopmental disorder defined by impairing levels of inattention, disorganization, and or hyperactivity and impulsivity. These points will be frequently repeated for you to understand. Okay, because these are core points frequently in different subjects, different options. I'll be repeating it. So by the end of this presentation, you all should be able to understand what ADHD is. So this inattention and disorganization entail inability to stay on task, seemingly not to listen, losing materials necessary for tasks at levels that are inconsistent with age or development level. That means a child is going to the school, we give a pencil, rubber, which is very normal for younger children to lose. That is absolutely okay. But when it is inconsistent with the age of the development level, there even the teachers and the parents start to observe. Now, hyperactivity or impulsivity entails overactivity. It's like fidgeting, and there is inability to sit in a stay at a place seated. They also include into other person's activities and inability to wait, symptoms that are excessive for age or development level. Clinical will talk later on, but if you have ever visited school, children's school, or if you have an opportunity to present in the school and all, you can see, which I have had, we can see few children are very calm, composed, will be attentive. Few children are not attentive because the subject is not interesting. But there are other children who are not able to sit in a place. The teachers are constantly monitoring that particular one child. So that restlessness is not up to their level of intelligence. Okay, that is something which we can see. Now, based upon ICD-11, WHO 2022, they have introduced the term attention deficit hyperactivity disorder under 6A05, disorders of attention and activity. Basically, they also say the same thing. Attention deficit hyperactivity disorder is characterized by persistent pattern. Now here, it should be at least 6 months of inattention and or hyperactivity impulsivity that has a direct negative impact on academic, occupational, or social functioning. There is an evidence of significant inattention and or hyperactivity and impulsivity symptoms prior to the age of 12. So even for an adult who have been diagnosed, there should be a history prior to the age of 12 of ADHD, typically by early to mid-childhood. Though some individuals like MC, they may first come to the clinic later on. So the degree of inattention and hyperactivity impulsivity is outside the limits of normal variation expected for the age and level of intellectual functioning. Okay, moving on, epidemiology. Just for, we know the global prevalence. 5 to 7% in children and 2.5 to 3% adults globally suffer from this. Gender, male is to female, 3:1. However, this is highly arguable because female coming forward with this condition, adult female symptomatology based on ADHD differs, which we'll learn. Okay, in childhood, and this narrows in adulthood. The persistence, like 50 to 70% of the cases continue into adolescence and then 30 to 50% into the adulthood. Basically, it starts about 12 and that's mandatory for the diagnostic. One of the criteria. Yeah, now we are going to enter into neurobiology of ADHD. I want all of you to be sharp, focus into it because we are going back into anatomy, chemical, neurochemical, everything will be going and touching into it. So basically, this will be integrative mode. That means the current understanding places ADHD as a multi-level neurobiological disorder. The structural deficits, neuroanatomy, functional disconnectivity, neurophysiology, chemical imbalance, neurochemistry, genetic susceptibility and environmental modulation, where epigenetic stress and effects will be discussed. Now, together, these produce the behavioral triad of inattention, hyperactivity, and impulsivity, not as isolated symptoms, but as expression of dysfunctional brain regulation. Let's start neuroanatomical findings. See. Okay. Now, ADHD is primarily a neurodevelopmental disorder of, let me see, where is it? Just a second, please. So, ADHD is primarily a neurodevelopmental disorder of frontostriatal and cerebellar circuitry. That means the brain networks responsible for executive control, motivation, and behavioral inhibition. Basically, it is structural and functional neuroimaging consistently reveals subtle but measurable deviations in specific brain regions. Now, we are moving on to the prefrontal cortex dysfunction. That's the first part. Okay. So, dorsolateral, ventrolateral, and orbitofrontal. The dorsolateral prefrontal cortex is crucial for working memory, sustained attention, and response inhibition. So the ADHD patients show hypoactivation in this area on fMRI, that is functional MRI, during cognitive control tasks. Now, the orbital frontal cortex is involved in the reward valuation, which shows decreased gray matter density, explaining impulsive decision making and altered reinforcement sensitivity. Now, the anterior cingulate cortex, this area is responsible for error monitoring and motivation, which also exhibits reduced activity correlating with difficulty in sustaining effort. So what happens is symptoms is how the child presents is poor impulse control, there is distractibility, difficulty in delaying gratification. They want an instant gratification. They can't have a long-term goal objective. Next, we move on to the basal ganglia anomalies. That is, it comes to the structural functioning imaging. Here also shows that there is abnormalities within the basal ganglia, particularly involving caudate. This area is caudate nucleus. This area is putamen and nucleus accumbens. The key component of the frontostriatal and thalamic circuitry that regulates the attention, motor control, and motivation. Move on to the caudate nucleus and putamen volumes. Now, what the changes? There is reduction in the volumes are reduced. That is, in MRI scan, we see the consistently reduced in children and adults with ADHD. Now, these dorsal-striatal nuclei modulate, like I mentioned, motor inhibition, the response selection, how they are going to respond to a particular event, and procedural learning through dopaminergic projection from the substantia nigra. That is near the brainstem area. There is one point. It's can't say near the, okay. Now dysfunction here leads to poor inhibitory control, hyperactivity, and difficulty in suppressing prepotent or automatic responses. Okay. Yeah. So this area is substantia nigra. Okay. Now, you know, this is the striatum. Now, the nucleus accumbens, which is this area, previous image you would have seen, part of the ventral striatum, plays a central role in reward anticipation, motivation, and reinforcement learning. So the functional MRI here, what does it show? It shows hypoactivation of the nucleus accumbens during reward. There is no why that will be in the neurochemical area. Okay. So now here nucleus accumbens, there is a hypoactivation during the reward expectation task, reflecting a blunted dopamine response in ADHD. So this underactivity contributes to what all symptoms we see. There is a delay aversion, there is reduced motivation for long-term goals, and a tendency towards immediate gratification or novelty seeking. Like these are the key behavioral features of the ADHD. Like no long-term goals, you can't just make them sit in one place. Okay. Now, because of this, there's a hypoactivation at this particular area. I hope I'm able to keep your attention here. Yes. So, see the overall dysregulation within the frontostriato thalamocortical loop, that is linking the previous slides I mentioned, prefrontal cortex, striatum, thalamus, and the cortex, disrupts the motor inhibition and reward-based learning. So these deficits explain the triad. What are the triad? Inattention, impulsivity, and hyperactivity. The summary is, see, the structural and dopaminergic dysfunction is what primarily is happening. Okay. So the caudate and the putamen accounts for motor hyperactivity, that particular area of the brain, and disinhibition. Nucleus accumbens are hyperactivity underlies reduced reward sensitivity. This is the summary what I've said. Poor motivation will be seen and impulsive reward seeking behavior. The child will be showing restlessness, distractibility, task avoidance, they are pro in procrastination. Like if there is procrastination, they're pro in that because they just want to avoid the task. Something which has to be done will be tomorrow, will do tomorrow. That happens. And there is like I said, instant gratification. So this is just basal ganglia structure I've summarized. What is the role of caudate nucleus? Primary function. It is, like I had mentioned, cognitive, control, then attention, response inhibition. For putamen, it is motor control, timing, habit formation. Nucleus accumbens, reward anticipation, motivation, reinforcement. What does it change when an ADHD? That is reduced volume and hypoactivation of the caudate nucleus. Putamen also reduced volume abnormal activation. Nucleus accumbens also shows hypoactivation, reduced dopamine response. What does it lead? The first caudate nucleus, the clinical manifestation is inattention and impulsivity. Putamen, the clinical manifestation is hyperactivity and clumsiness. Nucleus accumbens is daily aversion, low motivation, and novelty seeking. Now, cerebellar involvement. Like I mentioned, prefrontal basal ganglia, cerebellar involvement. We know cerebellum is basically traditionally associated with motor coordination. Also supports in attention shifting, timing, and emotional modulation. Yeah. How do you react? How much empathy you can have. Now, MRI studies demonstrate decreased volume in the vermis and posterior lobules linked to dysregulated timing and sequencing of mental tasks. Clinically, because of this, we can see the children with ADHD often show poor motor timing. Yeah. Then that is what clumsiness. In hurry. If you take a glass from the table, even in such a hurry that they can't even handle it and fall down. And even that they're not, serious about it. They're not regretful of that. They are in always a playful mood. They'll be like, even if they say sorry, they'll forget it. They'll get distracted. And sequencing error, which we'll be seeing in the cognitive motor integration test. Now, we move on to the neurochemical basis. We have done neuroanatomical basic brain structures, which all are involved in the ADHD, what all hypoactivations are seen. This is what neuroanatomical basis we have clear. Now, what happens inside there? That is what we are going to study in the neurochemical basis of the and which falls under neurobiology. So ADHD is basically not driven by as of the latest research, by a single neurotransmitter defect. Okay, deficit. It reflects a network level imbalance among dopamine, noradrenaline or norepinephrine, both are same, glutamate, GABA, and serotonin systems. So this disrupts each pathways, goes to the particular brain areas, which causes disruption in that particular activity related to that brain area, that is disrupting motivation, attention, inhibition, and emotional regulation. Now, the ADHD arises, but particularly from neurotransmitter dysregulation in cholinergic, that is dopamine and norepinephrine pathways, which control arousal, attention, and reward processing. Primarily, we believe it is due to dopamine pathway dysfunction. But I'll be include whatever the latest research I have introduced here. So, before we go into what all the pathways are, we'll just see what basically dopamine does. what norepinephrine does, what glutamate is expected to do, what GABA, gamma-aminobutyric acid does, and serotonin 5-HT is doing. So dopamine primary brain regions where all it acts is prefrontal cortex, striatum where caudate and putamen, and nucleus accumbens. Norepinephrine is locus coeruleus to prefrontal cortex and parietal cortex also. Glutamate, prefrontal cortex, ACC, striatum, cerebellum. Now, PFC for GABA, motor cortex, cerebellum, and basal ganglia. Serotonin is raphe nucleus, PFC, towards PFC, and limbic system and striatum. These are the primary regions of the brain where their effects are seen more. What are the normal function of dopamine? What does dopamine give? We all say, what is dopamine? We say, oh, I'm high in dopamine. It's a reward processing or motivation, attention, inhibitory control. Norepinephrine causes arousal, attention, cognitive focus, stress response. Glutamate has a function of major excitatory transmitter, enhances learning and synaptic plasticity. Now, GABA is primary inhibitory neurotransmitter, which regulates cortical synchronization and inhibition. Now, serotonin is a mood regulation. So, behavioral inhibition, reward modulation. First, dopamine dysfunction. So, here, this is a mesocortical pathway. That is, this is a VTA, that's a ventral tegmental area to prefrontal cortex. This shows reduced dopamine release and receptor density, which contributes to deficits in executive control. The mesolimbic, that is from VTA, that is ventral tegmental area to nucleus accumbens. What does it affect? It exhibits blunted reward signaling, leading to delay in aversion and preference to immediate rewards. Okay. Now, this imaging using PET traces and positron emission tomography traces shows decreased dopamine transporter density and D2 receptor availability at the striatum. Okay. Now, norepinephrine dysregulation. What does this happen? Yeah, this is LC, that is locus coeruleus. This modulates prefrontal attention networks. So from here, we can see everything that's motor and sensory functions during sleep or wakefulness. The whole network is going on for when it reaches hypothalamus, wakefulness and stress response, prefrontal, wakefulness, attention, behavioral flexibility, thalamus, sensory, attention, sensory processing. Okay, so now reduce any tone results in poor signal to noise ratio during cognitive tasks, impairing sustained focus. Now, non-stimulant agents like atomoxetine target this deficit by inhibiting any reuptake. What is this norepinephrine neurotransmitters? No, when it happens, this transporters gives a signal. It's just like a reverse pickup. Once the neurotransmitter has entered the brain, it gets activated and wants to bring it back to the original place. But that is the reason this is known as neuroabsorption takes place. Clear? So to avoid this what happens when excessive neuroabsorption takes place? The neurotransmitter level of the brain decreases. So these type of non-stimulant agents from from mainstream of medicine, they atomoxetine like group of agents, they target and stop any reuptake. Okay, they act as an inhibiting agent so that there's less neuroabsorption and the level of the norepinephrine is maintained at the brain parts for proper managing or continuing of the brain functions. It's basically that pathway. Now we move on to the serotonin modulation. Now, like I mentioned, the first table, it is at the raphe nuclei, which is at the brainstem. This 5-HT serotonin contributes to what? Impulse regulation and mood stability. So this altered serotonin transporter, function and receptor polymorphisms may explain emotional dysregulation and comorbid anxiety in ADHD, right? So we know that for anxiety also serotonin-related primary medicine is what being given for the mainstream of medicine. Or the GABA system. So GABA maintains inhibitory control over cortical excitability. Okay, so key regions are the prefrontal, motor cortex, cerebellum, and basal ganglia. Low GABA concentrations in motor and prefrontal cortex lead to poor impulse control and hyperactivity. So for now, till now, whatever we have learned, everything is low. Serotonin is low. dopamine is low, right? Norepinephrine is low. GABA is also low. So GABAergic deficits also disrupt oscillatory brain rhythms, beta or gamma, necessary for sustained attention. Now the glutamate system. Same image is there. This is the glutamate area. Here. So the emerging evidence shows elevated glutamine in ADHD, indicating excitatory overdrive. So all the other neurotransmitters we have it is hypo, that is decrease in amount, except glutamate or glutamine. So the key region here also prefrontal cortex, anterior cingulate cortex, and striatum and cerebellum. This leads to what? Unstable neural networks and cognitive variability. Now, glutamate interacts closely with dopamine and norepinephrine systems, influencing reward and cognitive control circuits. So basically, when glutamate increases, what happens? There is a cognitive variability is there, right? That's too much of excitement. That excitatory overdrive the child goes into. Because this glutamine is more. There is execution functioning is less because of dopamine less. Emotional regulation is less because serotonin is less. Motor activity and things are less because of the norepinephrine. Here it is more. Now, ADHD, basically what that means is ADHD is now viewed as an excitatory and inhibitory imbalance disorder rather than purely dopaminergic. This is the latest one, not completely we are following it. So far, very can't say not following it. I can't speak much about the mainstream, but dopaminergic pathway is what being core that has been discussed most. Now, excessive glutamatergic tone and insufficient GABAergic inhibition lead to unstable network dynamics. It's like a neural noise. Okay, there's short circuit in the system. It's like not properly wired. Now, this imbalance disrupts the signal precision, okay, in executive networks, explaining the variable attention and impulsivity hallmark of ADHD. Now, so it's like neurobiological pathway implicated in ADHD, just a table. So, concise one, so that what all you have read, put into table. What are the pathways? Most commonly seen are frontostriatal circuit, mesolimbic dopaminergic pathway, frontoparietal network, default mode network, cerebellar pathways, corticostriatal thalamic circuit, frontocerebellar circuit, noradrenergic arousal network. This default mode network is now like it's like when you're resting, yeah, when you're not thinking, when you're not doing anything. What do? We are in a self-realization. It is required. That network is a mode where we are in a calm place where we are self-realization is happening, where planning is happening, a futuristic thing, and that is all a default mode network. Okay, this is known as resting state self-referential thought. These are the key brain regions, which I'm not going to say. We can go through due time. These are the primary neurotransmitters like dopamine for the frontostriatal circuit and norepinephrine, mesolimbic dopamine, frontoparietal has dopamine, NE and glutamate. Okay. Now the core function for this circuit, first one, frontostriatal is executive control. Because whenever prefrontal cortex is coming, working memory is coming, inhibitory control is coming. Here, hypoactivation. That is reduced dopamine signaling. For mesolimbic, reward sensitivity and motivation, altered reward processing and delay aversion. Frontoparietal networks, sustained attention cognitive control, and reduced connectivity attention lapses. For DMN or default mode network, resting, that what I said is resting state self-referential thought, it gets affected. So there is excessive DMN. This is known as mind wandering. You keep on thinking. You are not, you're like daydreaming. These all factors can come because of the affection when this core function gets affected. Okay. Now, when cerebellar pathways is timing, coordination, and attention shifting, there is structural and functional abnormalities. Motor control and cognitive flexibility, there is delayed maturation and inefficient connectivity. When frontocerebellar circuit is error detection, timing regulation. Okay. And then noradrenergic arousal network is arousal, alertness, signal to noise control, reduced phasic NE response, and impaired alertness. Okay. Moving on to the neurophysiological aspects. So EEG findings. There is increased theta beta ratio. So basically the theta is between 4 to 8 hertz is increased. Now beta will decrease. So this change will cause the TBR ratio to increase in more than 4 in ADHD. Normally it should be between 2.5 to 3. This indicates cortical under-arousal. Now there is excess slow wave activity reflects inattention and reduced cortical activation. Now the stimulant medication and EEG neurofeedback normalize the TBR toward normal levels. That is stimulant medication like medication. How do we come back? And EEG neurofeedback we see when the TBR ratio has come down to normalization means there is improvement in the ADHD symptoms. Now we have this I have mentioned last time also ERP, that is event related potential findings. The electrodes are kept in the cerebral area and particular stimuli are given like on the go tasks are being given, and how the brain EEG functioning variations are happening. Based on that, we take note of it. So the poor attention resource allocation and working memory updating is found by that. There is slower cognitive processing speed we can see in these children. There is inhibitory control, go or no go or flanker task is reduced into amplitude impairment, weak performance monitoring and self-regulation. So overall pattern is there is abnormal timing and amplitude of attention related ERPs consistent with executive function deficits. Now functional MRI findings. This is lower goal, that is blood oxygen level dependent activation. So the functional MRI is this. How do we say this? See, when we do the MRI, when there is an activity happening in the brain, so the deoxygenated blood, it is more having magnetic attraction. So that gets activated. When the deoxygenated blood is runs towards that activity area, the oxygenated blood reaches there. So the excessive blood flow. Once that happens, it comes to normal. But during the phase of the deoxygenated blood activation is where we try to find out what all areas are getting active, and we create the report. So here it affects the dorsolateral prefrontal cortex, inferior parietal lobule, anterior cingulate cortex during sustained attention and inhibition tasks. So this functional MRI connectivity studies reveal underconnectivity between prefrontal executive networks and default mode network, like which I mentioned, which is like mind wandering, causing frequent mind wandering. So clinically, if you can see, the neural inefficiency explain why ADHD individuals lose focus even during simple and low demand tasks. So now there is genetic and epigenetic influences hereditarily. ADHD is one of the most heritable psychiatric disorders, like more than 74%. The twin and family studies confirm strong genetic loading across generations. So the candidate genes. So this is genetic aspect we are studying, which is that DRD4, dopamine receptor D4, functions as mediates dopaminergic inhibition in prefrontal cortex. Okay, and what is the effect? 7 repeat allele linked to novelty seeking and impulsivity. Now, dopamine transporter 1, it regulates synaptic dopamine reuptake. Okay, and SNAP25 is synaptic vesicle fusion protein, which altered release efficiency affects cortical signaling. This causes excessive data expression, that is low synaptic dopamine. Clear? When excessive data, that is dopamine transporter is more, like I mentioned in any transporter also, when it is more, it facilitates more neuroabsorption because their job is like a bus for return trip. From where you came, I'm going to take you back. This is for you to understand. So more neuroabsorption happens. So what happens here? Low synaptic dopamine when there is excessive data expression. Here, I think I read this now. The catechol O-methyl transferase, a dopamine degradation enzyme, it clears dopamine clearance rate, affects the dopamine clearance rate. So there is no single gene which I have said causes ADHD, rather than a polygenic risk, plus environmental factors which causes the vulnerability. Epigenetic. Say epigenetic is above genetic, like I had previously mentioned. It's like the planner. Like you give me whatever you want, I will decide what has to be done based upon how you have been exposed to various factors, right? So it has environmental influences which modify gene expression without altering the DNA sequence. So prenatal stress is a major factor. Maternal smoking, maternal stress, whether alcohol intake, lead, mercury exposure, which causes methylation changes in dopamine-related genes. Now, early life adversity alters histoneacetylation in neural plasticity genes. Now, some of these changes persist into adulthood also, potentially explaining chronic ADHD symptoms. Moving on to the core features. So we have technically completed the neurobiological aspect of the ADHDs, where we have covered about our neuroanatomy, neurophysiology, and neurochemistry, right? So now the core features, basically DSM-5 and ICD-11 both identify 3 major domains of ADHD symptoms. Before we move into what we are going to expect, right? The cognitive and emotional features. So there is basically impaired working memory and executive function. There's low frustration tolerance, mood lability, poor time perception, and reduced motivation for delayed rewards. These are the primary stuff. Now, from the beginning, I'm saying inattention, hyperactivity, impulsivity, right? These 3 are what we'll be taking one by one. So for inattention, cognitive deficit cluster, that is a persistent failure to maintain the focus and the mental effort. Symptoms must be developmentally inappropriate and inconsistent with the person's age or IQ. So at least the following symptoms will be seen, at least 6 for the children and 5 for adults equal or more than 17 years. For the following should be present for more than or equal to 6 months. Often fails to give close attention to details or makes careless mistakes. Difficulty in sustaining attention in tasks or play. Seems not to listen when spoken to directly. Sometimes they don't even look into eye. Or fails to follow through on instructions and incomplete work. Or difficulty organizing tasks and activities. Avoids tasks requiring sustained mental effort or schoolwork. Loses things necessary for tasks, example like pencil, papers, and keys, and easily distracted by extraneous stimuli, often forgetful in daily activities. Here, of this, minimum 6 for children and 5 points for adults for more than 6 or equal to 6 months. So clinically, daydreaming, there is disorganized desk or work habits, full clutter, incomplete homework, poor working memory, careless errors. Second one, hyperactivity, which is behavioral cluster. Now, this represents excessive motor activity inappropriate to context or developmental level. Symptoms: fidgets with hands, feet, or swims in seat. Leave the seat in situations when remaining seated is expected. Now, runs or climbs excessively in inappropriate situations. Unable to play quietly or engage in leisure activities calmly. On the go always, or acts as if driven by a motor. Like, talks excessively, like always on the go. Like the child is, even when the children are a bit more naughty, we say, oh, always is so restless, is always active. So, but it's not ADHD because it may be wasted depending upon developmental age. But that when it's not upon the IQ or developmental level, then that has an issue. Clinically, almost what I have explained: restlessness, excessive talking, constant movement, classroom disturbances, and poor sitting tolerance. Now, impulsivity, that is behavioral and emotional cluster, which manifests as hasty actions without forethought and difficulty delaying gratification. Symptoms include blurts out answers before questions are completed. Now, mind so. Maybe in a classroom for the teachers out there, the teacher might say the child is answering before I'm even he or she knows what the question I'm going to ask. This is not for the toppers. Like the topper children who are very studious, they will also answer before they're complete, and they are mostly right. That is not what I'm going to say. The child is not even willing to listen, understand what the question is, but blurts out the answers. Okay. The difficulty in the waiting turn, the queue, standing in a queue, or when they just want to run and go and finish task and run away and get distracted and do something else. Now they interrupt or intrude on others, like some other conversation is happening, some other 2 to 3 children are talking about something else, and the child will come and disturb and talk what is happening and interfere in their activities. Some project is going on, they will interfere, they'll scribble and then they'll go on, or they put the water on that lunch bag or down, and just for the sake, because that child is not able to have reached the developmental maturity enough to understand what is happening. And of course, there is underlying chemical processes, neurochemical shift changes that is there. Now, how clinical presentation, like say, interrupting teachers or parents, there's risk-taking behavior and emotional outbursts. So there is difficulty in cooperating games. Team player being the team player is a very difficult task for the children. However, as they go up, there are changes. Now, functional impairment domains. What are functional changes we can see here? The academic aspect, because we're mentioning academic and social and occupational level and all, they have a certain impairment. So what is academically? They are poor grades, incomplete task, lower self-esteem. Socially, there's peer rejection. Nobody can even talk to them. As children group are also, they are also having their own development of the personality going on simultaneously. They're also trying to find out and adapt to the societal norms and all. So when the other child or student who is having this ADHD is coming, and we're quite impulsive, quite irritating, they can't be that much empathetic. Like very few children are that much empathetic. So there is peer rejection happening. That's impulsive communication is there from the child's end also. Occupational, there is missed deadlines. He'll be unless and until they have learned to work with their problems or taken help from some medicine or taken help from some adjunct measures, it will be difficult for them to meet the deadlines. There will be conflict with the supervisors. And there is emotional irritability, low frustration tolerance, and comorbid anxiety also comes with this. So basically, that is the core features for both children and adult. Here, this is for overview for adult ADHD in men versus women. So, ADHD persists into adulthood in about 60 to 70% of those diagnoses in childhood. Yet, men and women experience and present it differently. This is what I said later, because where the ratio and the prevalence, we had approximately 3:1 for male is to female ratio. There are chances that maybe the women or ADHD in women are not that much well diagnosed because their presenting complaints or symptoms are presented differently. So, like there are leading to gender disparities in diagnosis, treatment, and outcomes. Recent research emphasizes that women remain underdiagnosed and undertreated largely due to bias in diagnostic criteria itself, historically based on male presentation. So, which I can clearly say here because most of us are women out here. Now, tabular form for easy understanding. The aspect is symptom presentation. For men, basically, they are more hyperactive and externalizing the behaviors. So, women, it is more a tone of inattentiveness. There is internalizing the symptoms, like more of daydreaming, more of forgetfulness, and also procrastination. That also is there with the women with ADHD. For men, often they are diagnosed earlier, childhood and adolescence. Usually for women, it is frequently diagnosed later, adulthood, sometimes post-childbirth also. Nowadays, it is slightly changing. Nowadays, this present generation, since we are more aware about these symptoms, the family is more concerned about girl child, and we are more, society is slowly turning into more, can't say feminist, but yeah, accepting women. So the recognition of the parent towards a girl child is also more seen. So this is the usual majority of the condition where the women are diagnosed later on. The comorbidities are a higher rate of substance use disorder and antisocial traits because they are not able to control their emotions. So they fall into the substance use problem. Okay. Now there is higher rate of anxiety. Okay. Now there's overthinking will come here. Now depression will be anxiety or depression and emotional dysregulation is happening here. Social outcomes, because more occupational instability and legal issues they'll be facing because of the hyperactivity and externalization behavior and conflict with the supervisors. Here, more relational stress comes, lower self-esteem and masking behavior. What's masking behavior is, I'm okay, I'm fine. Even if they're not understanding, they try to be with the peer group or with the social group, with the relations, being present there even when they are not present, even when they are not understanding, even when they want to run. So they are good in masking. So these women do multitasking by masking many of the times. So because of masking behavior also, there will be social outcomes, how it is being expressed. Hormonal, there are less hormonal functional impact. Then here for women, estrogen, progesterone changes influence the ADHD symptom severity. Coping styles, like I said, men are very externalized from frustration, impulsive actions. You're internalizing the distress, perfectionism, and overcompensation. Now the diagnostic criteria for the ADHD. Also for the core features of the DSM and the ICD, I think I have given you a link. Let me check. Okay, I think it's not here. Maybe I'll just forward because there's a site where complete detail of the categories are mentioned, the tabular form. So I have given, I thought I've mentioned it. Maybe I could have. Okay, so let's move on to diagnostic criteria and under DSM-5. Same thing which you have mentioned, the core features also. This duration, which is about 6 months or equal to 6 months. The age of onset should be before 12 years of age. That symptoms present should have 2 settings, at least minimum 2 settings or more than 2 settings. Settings means where all the problems or the symptoms is marked. Okay, either home, either school or work. Now, functional impairment is must. Okay, it should be must and cause clinical significant distress or impairment. So exclusion not better explained from some other conditions. Okay, like anxiety, mood disorders, and all. Now, diagnostic criteria under ICD-11, basically 4. Occur across multiple settings, same to DSM-5. Symptoms must appear before the age 12. Persistent pattern of inattention and or hyperactivity or impulsivity must lead to significant functional impairments common. Now, classification. Both of them have more or less similar classification. The type is predominantly inattentive presentation, ADHD1. Predominantly hyperactive impulsive presentation, ADHD HI. Combined presentation, ADHD-C. Now, what is the description? For the inattentiveness, there is a significant inattention, but minimal hyperactive impulsive symptoms. So that means it's not absence of any hyperactivity or impulsiveness. That symptom is also there, but there is minimum. So there are points. These are diagnosis based. These are the points that we have mentioned. More than or 6 of the inattentive points, category under inattentive, there are further points. I've just given a crux of it. And more than or less than 6 of the hyperactive or impulsive symptoms under that category, those pointers should be met. For the hyperactive impulsive presentation, that is ADHD HI, there's a marked motor restlessness and impulsive acts and few inattentive symptoms. So 6 or more points under the hyperactive impulse criteria and less than 6 under the inattentive symptoms. The combined presentation, there is both inattentive as well as hyperactivity, impulsivity criteria should be met. Both should be more than 6 points, equal or more than 6 points. Symptoms in both of the clusters should be met. So basically, DSM-5 eliminated the terms. This is a pointer that I mentioned. The subtype, you know why, and it was put into presentation. Because recognizing that the symptoms may change, the presenting symptoms may change over time. That means for presentation type, may change, like the child is having ADHD, HI, hyperactive impulsivity in childhood, may evolve into ADHD inattentiveness in the adolescence. So that's why it's changed from the subtype terminology to the presentation terminology. Yeah, I've given the link here. So this just once we get this, I will try to add this to the PDF also. Just click onto the link and you can see all those criteria that I've said under the clusters of hyperactivity, impulsivity, and inattention. So that we can you can see clearly. Also, it has a differentiation of the DSM-5 as well as the ICD-11. Basically, ICD-11 also, what's the differentiation with the DSM-5 or the particular category is almost every criteria and the clusters are same. It's a few terms, that is the partial remission. ICD-11 introduces that aspect, specifier for individuals whose symptoms no longer meet the full criteria but continue to cause impairment. There are no full criteria. They're in a halfway through. Okay, but there are causing some impairment. No, it explicitly includes adult ADHD and allows flexibility for coexisting of emotional dysregulation. What are the standardized assessment tools? So basically, diagnostic workflow is, previously I've mentioned the screening is there, clinical evaluation is there, functional assessment is there, the same way. There is clinical evaluation where there is detailed history has to be taken. Symptom checklist based upon DSM-5 and ICD-11 criteria. Rating scales, Connors 3, SNAP 4 or Vanderbilt for children, ASRS for adults. Cognitive or neuropsychological testing, CPT, VSCST, TMT, Wechsler. Functional assessment, brief, BRIEF or APRS. Now, optional adjuncts. See, these things like EEG, what all we have mentioned, EEG, theta beta ratio studies, fMRI, PET for neurobiological insights. These are all not diagnostics tool per se. These are all for research purposes it's required. So the ADHD diagnosis is basically clinical, based primarily on a thorough history and a symptom checklist. Okay, that which has to be based on the DSM-5 or ICD-11 criteria. Everything is being given unto that. Now, standardized behavioral rating scales has been followed and neuropsychological tests to assess executive function. Objective tests like how I have mentioned, EEG, MRI, PET are not diagnostic tools. They are just used mainly for research. And one more thing I want to say that it's like, it's a multidisciplinary approach. It remains the same for all, like all neurodevelopmental disorders. Okay. No, first point, clinical rated scales. So it's basically used to quantify the symptoms and compare across the settings, whether home, school, or work, and track the treatment response. Okay. So, like, what are the tools here? Like I mentioned, Connors 3rd edition, which is basically the target group of 6 to 18 years. The parent, teacher, and self-report, but the child is adolescents and near 17, 18 and all. What does it measure? It measures the inattention. It measures the hyperactivity, okay, impulsivity, defiance, and learning problems. It provides a T-score for comparison with norms. So it's for differentiation also. The ADHD rating scales, ADHD RS5, which is between 5 to 17 years, 18 item scale based on DSM-5 criteria. Now, each item rated on frequency, that is never to very often. Used for both diagnosis as well as treatment monitoring, like how well the child has improved. So when the reading has been come from never to very often, the variation helps us to monitor it. Swanson, Nolan, and Pelham questionnaire is 6 to 18 years, 26 item as there, where parent and teacher scale is there. It covers inattention. What are pointers are there? Inattention, hyperactivity, and oppositional defiant behaviors, which is used both for ADHD and ODD screening. Now, Vanderbilt, the ADHD diagnostic rating scale for the age group of 6 to 12 years. The school-based, that is, it includes ADHD symptoms and comorbidities, ODD, anxiety, depression. One of the most widely used primary care tools. Okay. Now, this is for adult, 18 years or more. This is an 18-item self-report developed by WHO. Part A, 6 questions, serves as a validated quick screener for the adult ADHD. Now, that is neuropsychological batteries. Batteries are basically a set of tests, nothing else. Now, assess, what do they do? They assess the executive, attentional, and cognitive deficits that underlie the ADHD symptoms. So these help in differential diagnosis, example, ADHD versus learning disability and everything, and treatment planning. So CPT 3, what does it assess? The sustained attention, vigilance, and impulsivity. So it measures the reaction times and errors. So ADHD patients show increased omission or inattention and commission or impulsivity errors, highly sensitive for attentional lapses. Now, trail making test. There is cognitive flexibility, visual scanning, processing speed. So ADHD patients take longer and make more sequencing error, reflecting poor set of shifting and executing control. Sequencing error is like, I'll come forward to explain more than like one pattern has to come follow. When you tell one thing to be done in the sequence and they following that order is difficult. Now, Wisconsin card sorting test, it's an abstract reasoning, the VSCST. It's abstract reasoning or set shifting, multiple flashcards like abstract cards are given. So the ADHD patients show more perseverative errors, that is failure to adapt to changing rules due to frontal striatal dysfunction. Professional intelligence scale or working memory index is also known as, it has a short-term memory, accessing the short-term memory attention. Mental manipulation. So ADHD, what they usually show a lowered working memory, which you have been knowing so far. Now this index compared to verbal or performance reflects poor executing working memory. See, these tests do not diagnose ADHD, but objectify the executive function, dysfunction consistent with it. They are good. They are especially useful in borderline or comorbid cases. So now, functional and behavioral assessment tools. Evaluate how ADHD symptoms affect daily functioning, academics, and executive behaviors. So basically, it is clinical assessments. Okay. Behavior rating inventory of executive function. So everyday executive skills, like organization, working memory, inhibition, these are all assessed through this tool. So completed by parents and teachers, it identifies the functional impairment beyond simple attention problems. Okay, well, he's not attending the class, he's getting distracted in the class. That is not could be because lack of interest in the subject. So this differentiation is mentioned here. Now, academic performance rating scale, that is impact of ADHD on schoolwork or productivity and learning. So it is used by teachers to rate the task completion, effort and accuracy, useful for educational accommodations. Okay. Now, ADHD cognitive task. Yeah, this is like clinically we can use this. You know, we can test it for us to come into a conclusion after all this questionnaire and all. So one is serial subtraction. Right? For example, like I mentioned, this is an example only, 100 minus 7 is not per se written in rock or something. Any sequence, you ask the child to subtract that particular number repeatedly from 100 aloud without using paper. So what happens in ADHD is, it tests sustained attention and working memory. Now, ADHD patient often lose track, make skips or stop prematurely due to inattention. Uria's three-step motor sequence is fist, edge, palm. That is fist, edge, palm. Okay. So this demonstrates it's not only for ADHD, for other conditions, Alzheimer's, and also for later on conditions also it happens, because just we have to understand which area of the brain is not affecting. Now, so like I mentioned, the demonstration is the fist, edge, and palm. We keep on asking the child to do it in the same order in a particular rhythm. Okay. Now, this acts as the motor sequencing and inhibition. ADHD children may perform impulsively, skips the steps, or fail to maintain the rhythm. Now, digital repetition, forward and backward. Asking, say a series of numbers slowly, any particular number slowly, and ask the child to repeat the same sequence forward and backward. Okay, in the reverse order. This measures the attention span forward and working memory backward. ADHD children typically have reduced digit span, especially the backward one. Because attention also they can up to a level, say wait, try, but working memory is not up to the par. So thinking on what we have said the numbers and repeating it backwards becomes a chore for them. Now, knock, tap, test, or go, no go task. So it is knock is when the physician is saying knock, the child has to do tap. When the physician is going tap, simultaneously the child has to do tap, knock. So in no go response also, go is a green light, for example, but withhold the response to no go. What is that? I do not know how many of you have played, but in school we used to do this. In Hindi, I'll be saying like tota ud, maina ud, kawa ud. So this is also one sort of test where we know that certain things doesn't fly, so we should not lift our fingers. So this is also a sort of task which can be put into test while we are trying to diagnose or confirm our diagnosis clinically. Evaluates impulse control and motor inhibition. ADHD children often respond impulsively even when instructed not to. Now, coding subtest, that is, they provide a key showing symbols for digits 1 to 9, and child fills in as much as matching symbols, okay, as possible within 2 minutes. Now, test is processing the speed and sustained attention. ADHD children work slowly and they make omissions or lose the consistency. Differential diagnosis. So common comorbidities are like behavioral, emotional, learning, neurodevelopmental, and substance use. So with behavioral, with comorbidities, we can see is ODD, oppositional defiant disorder, conduct disorder. Emotional, it can be overlapping with anxiety and depression. And learning, dyslexia with a comprehension dyscalculia with the reasoning. Now, neurodevelopmental, autism spectrum disorder and tic disorders. Substance uses, nicotine, alcohol. So for ODD, how do we differentiate is that it's a willful defiance. It's not inattention. It's like, I will not do it. I don't want to do it. It's not they're not able to, but they don't want to do it. Now, anxiety disorders attending attention due to worry, fear, or distractibility. Depression is poor concentration, secondary to low mood. ASD, social communication deficits, restricted interests. Learning disorders, inattention limited to specific academic tasks. And bipolar differentiation distinguishing units, episodic mood changes versus persistent symptoms. Okay, now we are coming to the homeopathic management. We all know the basic core of homeopathy. So disease is viewed as a dynamic disturbance of the vital force, and it is manifested as a behavioral, cognitive, and emotional symptoms. Now, here ADHD symptoms reflected disorder in cerebral regulation, often rooted in psychogenic and miasmatic causes for us. So soric, psychotic, and syphilitic. Soric, wherever there's inattention, daydreaming, laziness, poor memory. Psychotic is impulsivity, obstinacy, disobedience. Syphilitic, destructive tendency, violence, aggression. What do they demand? For everybody, every condition that comes to us, for any case, not only neurodevelopment, whether it comes female contains anything we are treating, we go for individualization. We have to understand the bias. There has to be dynamic remedy selection. But for here, we have to have parental counseling. Causative and maintaining factors. Hereditary predisposition should be checked. Okay. Prenatal influences, whether there is maternal stress, fright, grief, anger during pregnancy, should be noted down. Vaccination effects after head injury is there, any excessive screen exposure is there, toxic metal load like mercury, lead was there, which can act, which is even continuing to be having, act as a maintaining causes. This has to be taken note of. Family dynamics like parental conflict, lack of routine or neglect. Case taking approach, we have to take physical general, right? Sleep pattern, appetite, thermals, perspirations, cravings, mental generals, child interactive style, both what the child with the social behavior, response to authority, play pattern, not only how it's school, what has been objectively said, subjectively said, what is happening in our clinic. Maternal history is very important, mental state during pregnancy, labor trauma, medication or emotional shocks. And family history, like if there is any psychiatric disorders, if there is any addictions, any thyroid autoimmune conditions. So the common rubrics that I have mentioned. Yes, so it's mind-related rubrics is most, where the child is having concentration difficulty, attention difficult to fix, there is restlessness in children, activities increase, impulsiveness, impatience, destructiveness, mind talks insistently, loquacity and foolishness. So these are the mind symptoms, mind repertory, sorry, rubrics. And mind when there's fear, darkness of, fear being alone in children, company desire for, clinging children to mother, where there is violent anger, child striking others, talks rapid, love for music, desire for dancing. No? Then there is weeping alternating with laughter, sensitivity emotional. So these are the few rubrics. Confusion of the mind, contradictory action, mind egotism, delusional pursuit by enemies, precocity, mental, playfulness, foolish behavior, silliness. This I'm just randomly reading. You can go through it in your own time, please. Sleep disturb, restlessness during sleeplessness from activity of mind, overstimulation effects of imagination active. So maternal factors which are predisposing to ADHD. So how will that can be taken is mind ailments from anxiety of mother during pregnancy, from fright of mother during pregnancy, ailments from grief of mother during pregnancy, ailments from anger of mother during pregnancy, the shock after fright in mother, effects on child, mentioned Kent and Murphy. So mind anxiety during pregnancy of mother, mind fear, death of during pregnancy, ailments from vexation with anxiety, ailments from loss of mother, absence of affection. Similarly, if you in that order, disappointed love of mother during pregnancy, in difficult parturition, mother's anger during nursing. So my answer. So you're all here. I believe you are still here, not at all dozing, not at all getting distracted, since we are in ADHD. So the basic part is over with the neurobiology and everything is over. Now this again we need attention because this is my mathematic background. So I just wanted to give a wake up call for all of you. Okay, fine. Okay, let's start. So here the miasm, good. So here's miasm. Now, Soric. We have Soric, inattention, there's daydreaming a lot of, mental fatigue is there, poor memory, anxiety about the performance, right? But see, mild restlessness is there, there's fidgety is there, there's emotional sensitivity, the child has a lack of confidence, they're easily discouraged. These are the common remedies. I'm not going to read the remedies, okay, which most of us are well aware of these remedies. Now, for the psychotic, how does the child present? What is the basic trait of it? There's an impulsivity, right? There's an obstinacy. There's secretive or deceitful tendency. Suppressed emotions are there. So, how does the child present the characteristic expression? Overactive physically, but mentally are lazy, hurried, disobedient, and seeks excitement and pleasure, sensory-seeking behaviors. First thing that always comes to my mind, and usually I do is give us Medorinum. Then Tarantula has always helped me a lot. Now, syphilitic, when it comes, there is destructive, violent, aggressive, self-injurious, and harmful, immoral impulses. So there is extreme restlessness. There's intense temper, destructive tendencies, and obsessive or compulsive acts, poor moral control. There's stramonium, Alzheimer's, etc. Okay. So the further tubercular. How do they say? They have changeability. Whenever we say tubercular, we know there's a restlessness, changeability, impatience, dissatisfaction, desire to travel, constant change. So they have, the presentations are like alternative moods are there, the restless and creative, hyperactivity with intelligence, rapid burnout, and boredom with monotony. Psychosoric is alternation between dullness and restlessness, mild suppression of emotion with fatigue and irritability. Functional ADHD with emotional ability and vacillation between activity and inertia. Okay, please, it may mimic tubercular also here. So we have to have a careful differentiation. Now, and anxiety about incapacity. Psychosyphilitic is deep impulsive tendencies with destructive and antisocial patterns, high intensity with moral and behavioral distortion. Shows us hyperactivity mixed with aggression and deceit, inherited or familial ADHD traits, emotional volatility. Now, cancerinic is over-disciplined. They're more perfectionists. They're very oversensitive. They want stuff to be done their way. They're more responsible people, children. They take the responsibility very high. So, and emotionally, so they suppress and seeks harmony, approval. They're conscientious, anxious, guilty, yet internally restless, loves music, art, animals, background of parental control or domination. Pointers? See, most ADHD cases today are polymasmetic, often psychotic, tubercular, cancer, many combinations. Psychotic level, when it is there, is often the base functional, so it's the reversible stage. Now, syphilitic manifestation require a deeper constitutional correction. Now, tubercular and psychotic traits respond well to intercurrent remedies, which has to be introduced for almost all the cases for nowadays. And cancerinic layer commonly appears in children under strict, emotionally repressive parenting or perfectionist tendencies. Now, psychosyphilitic expression is seen in destructive, impulsive, and hereditary ADHD patterns. These are just the pointers. Takeaway. Potencies and repetition. Basically, see, this potency stuff I have always mentioned. It's clinical or doctor's experience. Okay, the more we experience, the more we deal with these cases, it varies, the judgment varies. So basic, for giving a standard form, I've given low potency 6C to 30C for sensitive or acute phases. The high potency, when you know the case, when we have chosen the correct constitutional remedies. For repetition is based upon the susceptibility and response. And then we have to observe how much the behavior has shifted, and the sleep pattern changes are also beneficial for them. Non-medical homeopathic support. What all things we have to do? Like I mentioned, it is a multidisciplinary function. There is a parent counseling and family dynamics correction should be introduced. It should be structured routine, sleep, diet, study, play. They lack structure. So they have to be trained slowly to fall into a routine where the structure is there. Now, therapeutic education and behavioral reinforcement. elimination of maintaining causes, screen overuse, artificial food, processed food, artificial food colors, sugar. These things have shown a very much effect on maintaining the ADHD symptoms. Now, behavioral and psychotherapeutic therapies has to be followed, like CBT, parent-family therapy, behavioral modification and token systems, social skills training. What is the purpose? It improves the impulse control. This is family harmony, because we have said also before also ADHD, like in epigenetic factors, we have family dynamics that play a huge role, and how it is how it can act as a maintaining factor also. So family harmony is maintained, and self-awareness is there. Mind, body, and lifestyle therapy, like you do yoga, pranayama. I just mentioned 2 or 3 asanas, which I have not much knowledge about, but I have found out from few of the research that these are good. Now, mindfulness and meditation for focus. Now, neurofeedback or biofeedback. What is the purpose? It balances the autonomic activity and enhances the focus and reduces anxiety. We all know yoga is good, irrespective of whether you are having ADHD or non-ADHD. It is very good for us as stress relieving. Whichever stage of life you are, whichever age you are, for children, it is very good in increasing the focus. Already, even for a neurotypical child also, yoga is very, very beneficial aspect of our life. Meditation is also very useful for them, especially in today's fast track life, where easy gratification, instant gratification, easy success, easy money making concepts are what is being taught and expected in today's societal norms. Like if the success is symbolizes being rich, being having money, that is what it is linked. So this instant gratification, the stress that the school and society provides, so all those things are asking me, it's not the purpose, but yoga and pranayama or meditation helps us and help the child to pull back, to realize what the potential is, to realize it's not about the daily life, whether it be neurotypical, whether it be neurodivergent. It is always helpful to bring on to the focus, bring on to improve the attention. Nutritional and lifestyle support. We know omega-3 rich diet is good for everybody. Avoid artificial colors and preservatives, good for everybody. Reduce refined sugar and processed foods. Supplement magnesium, zinc, iron if deficient. Now, this supports the neurotransmitter balance and brain nutrition, which was the first part altogether. Now, occupational and sensory therapies. Now, occupational therapy, like fine motor, self-regulation, sensory integration, like they ask them to do cycling, ask them to swimming, martial arts, so which enhances the coordination and sensory modulation. This is the reason why previous generation, most of us were able to train ourselves in a way because we were more outsiders. We used to go out and play, right? We used to have a lot of cycling, we used to have swimming, forget martial arts. We had some sort of exercise regime going on. So that is very good in coordination and sensory modulation, right? It will help in the adapting, whether the child has ADHD, whether that that time the child had ADHD, it helps in adapting. It helps in introduction to the society and managing tasks well. Now, educational and expressive therapies. Now, special education, remedial teaching, art and music therapy. Now, singing and dancing, it is very good because the rhythm, like I had mentioned, the rhythm, the constant memory of the steps, but it is dancing, the constant ragas that we have to memorize, the sequence of the ragas we have to memorize. This all helps the child to focus, increase the attention. So there is a play therapy for emotional regulation. So purposes develops creativity, discipline, and emotional expression. No, please, this one point, digital and cognitive support tool doesn't mean that we should ask our children to go and start playing games. This is completely different. Okay, this is the ADHD brain training games or apps, which is EEG based neurofeedback, which improves the sustained attention and working memory. Support and coaching, ADHD coaching for teens and adults, which is important because parent and peer support groups, there has to have a moral support, support system has to be developed among the students, among the parents. It is a teamwork eventually, right? And this is the initial stage. And for teens, they have to be aware of their, their points where they are not able to perform well, why they are not able to perform well. So there's coaching going on. So this builds time management. They have a good motivation, and family resilience is also there. You have to have patience to get to overcome this, to manage this. No? So these are the references for what all things I've done here. But like I said, there are additional points, which I think last time Dr. Vanitha ma'am had mentioned. So I thought I'll just introduce that, which is ADHD versus mobile smartphone addiction. See, it's basically a small overview I'm giving. Like I said, nowadays almost everybody will be saying I'm having ADHD. Adults, I don't know about you all, but whenever I watch any ADHD related, there are 100 people who are adults. I feel I am ADHD. Eventually, I have also started to feel that I have ADHD. That level that I have come. All the symptoms I'm having, I get totally distracted immediately. I'll be doing something, I'll forget. No, that's like I keep something on the stove, which is very common for women. Okay, we'll keep something on the stove, the kid calls, we'll go, and then we'll forget that something is on the stove. No, we can't diagnose that for ADHD, right? It is because we are not focused, we are doing multitasking. So that differentiation is not there in social. So they have self-diagnosed. But why? So it is not neurodevelopmental, it is behavioral. Okay, that is the difference. So in ADHD nature, there is a neurodevelopmental disorder. If you see properly for the research purpose also, the brain scan itself will show there are changes in the structural changes are there, functional changes are there, right? But that is not seen much in the mobile smartphone addiction. That basically behavioral addiction. It's a learned reward-based trait. Okay, etiology is neurochemical dysregulation like dopamine, norepinephrine plus genetic factors. Here, this is excessive digital stimulation. That is a maladaptive reward conditioning. This brain gets conditioned, but it's a maladaptive. Okay. Early childhood. Now, here that is seen in adolescence or adulthood, secondary to environmental exposure, but this is going to change because nowadays from children from this, I don't know, from 5 to 6 years itself, they are watching. So here this mobile smartphone addiction, which is more in adolescence or adulthood, gradually change. I hope it doesn't, but I foresee that change might happen in future. Now, the core symptoms here is inattention, hyperactivity, and impulsivity. But here it is compulsive mobile use. There's a craving. Okay, then there is a withdrawal, and there is I've mentioned tolerance level is not much. That's basically intolerance towards not giving that mobile. If you take the child mobile away from the child is like, if nowadays I get more mobile and smartphone addiction to children than the ADHD, to be very honest, because the child is not studying. The children now, because of social stuff, they are saying, "Oh, my child is having ADHD." No, there is, before even having diagnostic assessment, we can understand how the child is behaving there in the clinic because the child is with the mobile. Oh, you keep the mobile, I will tell the doctor, auntie, whatever it is, and then I can take. You take the mobile in between. If you give me the mobile now, either the child will refuse, depending upon the constitution of the child, will refuse, the child will give and then start crying, or they'll give and is calm, or not give and is calm. So that varies upon this constitution, but child is having the mobile. Now, the brain regions, prefrontal cortex, striatum, and cerebellum. Here, ventral striatum, orbitofrontal cortex. I think you remember the image where the prefrontal cortex, the third one, lower one is the orbitofrontal cortex, and insula is getting activated. Here, the executive function deficit is there, and here, reward system overactivation. So, this brain functions are getting activated. The structural changes are not there. Okay. Now, inherent a neurocognitive deficit leading to secondary reward seeking. Here there is learned extrinsic reward dependency. Yeah. So, why do we feel it is mimicking? Okay. So ADHD is inattention. So it gets mimicked in mobile addiction also. Like, hi. Why inattention? Notifications are popping up. Okay. The child is playing one game, some other notification come, clicks on it. So there is multitasking, leaving through fragmented focus. Now the parent thinks it's because of inattention. One thing I asked him to do, one game he was playing or she was playing, but then I can see she is doing something else. Hyperactivity sometimes can be seen in the mobile addiction. There is constant device handling, restlessness when disconnected. Impulsivity is also there in mimicking the mobile addiction, where there is immediate response to alerts and social media compulsions. Poor academic performance, yes. But this ADHD child is literally having neurochemical problems, and this child is totally addicted to the mobile, and that is causing functional changes also slowly. It has having reduced the sustained attention and procrastination. Now, emotional ability is there, which mimics in the mobile addiction. Here, there is dopaminergic fluctuation leading to the brain gives the dopamine factor, no? So that leads to the mood swings. Now, difference in etiopathogenesis. So the primary origin for ADHD is genetic and neurodevelopmental. For mobile, it is behavioral, like I mentioned, conditioning and reinforcement, right? Now it is basically 12, I had mentioned before also, it's adolescence. The course is chronic, may persist into adulthood, and this is acquired and potentially reversible. It is properly managed. Family history is often positive, and here mobile addiction is usually absent, which I completely disagree. I have seen nowadays, even for family history, the mother or father are also having this addiction. They are also constantly on the phone or that. So this is just for the sake that we can mention. But mobile addiction is family history. It's not genetically transferred. That's what they're saying. Now, response to stimulants, there's improvement. This is worsening, more craving and impulsivity is there. Now, EEG findings, elevated theta beta ratio, but usually this is normal or there is a mild arousal pattern. Comorbidities are ODD, learning disorders and anxiety. And then there's anxiety, depression and insomnia. See, what the note is, smartphone addiction often develops secondary to ADHD. And the ADHD patients are more vulnerable or addictive to digital behaviors due to the impaired inhibitory control and the need for high stimulation, right? They just want something very high, something which is making instant gratification. See, if symptoms are recent, are device related, are worsen only during phone use or deprivation, and remit after detox or screen limitation, then likely mobile addiction or behavioral mimicry. If it is begin before 12, occur multiple environment settings like home, school, work, and persistence is there irrespective of the device availability, then ADHD is likely primary. A coexistence, that is dual diagnosis. Its study shows up to 40 to 50% of adolescents with ADHD exhibit problematic smartphone use. That is ADHD, impulsivity, increased reward-seeking behavior, and all the games that you can see, like Roblox, you mention this Minecraft, then Call of Duty. These are having very high reward giving stuff. So one level crosses, the child requires another reward. So it keeps on building stuff by itself. So there becomes a compulsive screen behavior. Over time, this worsens the attention deficits, creating a vicious cycle. So in such cases, the smartphone addiction is secondary to ADHD, but can exacerbate the symptoms, complicating management and therapeutic adherence. So ADHD, we have these things which I mentioned: mobile phone addiction, we have smartphone addiction state, internet addiction test, and mobile phone problematic use skill, which are not get into the details. So basically, when a child comes, always assess for ADHD first using structured DSM-5 criteria. If symptoms correlate temporarily with mobile use, administer this smartphone addiction scale, SVS adjunct. Now, observe if behavioral modification improves the attention. If yes, then addiction was most likely primary, because only behavioral modification we have introduced. Clinical management for mobile addiction is behavioral therapy only, digital detox, CBT for behavioral addiction, screen time restriction, mindfulness training, and often is reversible with therapy. Basically, the mobile phone addiction can mimic ADHD through secondary attention impairment, impulsivity, and poor executive function. But however, ADHD is a neurodevelopmental disorder with early onset and biological underpinnings, while mobile addiction is a learned behavior dependency. So the smartphone addiction can be considered as a differential diagnosis and often a comorbid condition in evaluating ADHD-like symptomatology. So these are the references for this particular part of mine. So do we have time for one or two cases? This is already 8:15. If not, we can do it some other time.
It's already beyond the given time, I think.
I know.
So,
it's okay. It's not a problem.
Yeah.
Yeah, it's not a problem. Just one or two cases, not much detailed. We'll just go on. The time will just extend, right? So anyways,
Yes.
In learning, you will teach, and in teaching, you will learn by Phil Collins. So I may have fallen short. I am willing to learn. So as sharing is sharing, and from you also, I can learn more. So thank you for this opportunity, where actually I also had my own learning in a very unique way. So thank you so much. Over to you, ma'am.
Yeah, thank you so much, ma'am. It was a lot of information. You've given us a lot of details regarding ADHD neurobiology. Maybe we'll have to go back over and over to the slides and, check on that again. It is really hard to grasp everything all at once.
I agree. I agree.
But I'm glad you have included the addiction part of the mobile as well, which is the need of the hour right now.
Yeah.
Uh, it is really interesting. I request the audience to please post your questions in the chat box. We'll just wait for a while if, somebody is wanting to ask any question. No questions from the audience?
It's okay. I mean, I do understand it was too much of information. And
Okay, ma'am. Yeah.
anything you can get back to me in the WhatsApp.
Yes, ma'am. Thank you so much. So we will proceed further. Now I would like to invite Dr. Vidya Lakshmi Prakash to deliver the oath of thanks. Dr. Vidya Lakshmi is a fourth generation homeopath with over 12 years of clinical experience practicing in Dubai. In addition to her expertise in homeopathy, she is a certified health coach from the Institute for Integrative Nutrition, offering a well rounded approach to health that integrates nutrition, lifestyle, and preventive care. She also serves as an examination panel member for the Dubai Health Authority, contributing her expertise to uphold the highest standards in homeopathic practice. Over to you, Dr. Vidya Lakshmi. Dr. Vidya Lakshmi, are you there? Kindly unmute yourself. Kindly unmute yourself.
Sorry, my phone had a glitch. Thank you, Dr. Rashmi, for the introduction. Good evening, everyone. It's an absolute privilege and heartfelt pleasure to deliver the vote of thanks for today's beautiful webinar, Key to Neurobiology of ADHD and Homeopathic Management, hosted by the IHMA National Women's Wing in association with our UA chapter. First and foremost, I want to extend our deepest gratitude to our chairperson, Dr. Halloween, whose vision and constant encouragement continue to inspire us all daily. Ma'am, your leadership has been the guiding light behind this beautiful initiative. A special word of appreciation to our National Wing convener, Dr. Jagadi, for being the pillar of support and enthusiasm that made today's event possible. Your dedication to empowering women professionals and promoting knowledge is truly commendable. Our heartfelt thanks to our brilliant speaker who has dealt with a very difficult topic for the day in enlightening and well articulated, I must say, because it is a very, very nut cracking, brain cracking topic. You have unraveled us to the beautiful neurobiology of ADHD with such clarity and depth, and beautifully connected it with homeopathic management, which with short of time we could not, cover the cases, but definitely we will be going in for that during the, subsequent sessions, and helping us see both science and the soul behind healing, because we are all walking away with the renewed understanding and inspiration. We have to read more on neurobiology. That is the take of the day. And warm thanks to Dr. Danya for her graceful welcome that set the perfect tone for the evening, and Dr. Amarjeet for the thoughtful introduction of our beautiful faculty. Your words added warmth and comfort to the session. A round of applause as well to our MC, Dr. Rashni, who's always been, graceful and energetic and keeping us all engaged throughout. And of course, none of this would have been possible without our wonderful audience. Your presence, curiosity, and participation made this session truly vibrant, though it was a very difficult topic. We have to address that. A sincere thanks also goes to our ISMA UA chapter team the silent yet strong force behind the scenes. From planning and coordination to the technical setup, your teamwork has been the backbone of today's session. As we close, we carry forward the spirit of learning and collaboration. May today's insight help us serve our patients with greater empathy, understanding, and scientific precision, along with our beautiful science, homeopathy. On behalf of IHMA National Women's Wing, I once again express our heartfelt thanks to everyone who made this evening so special. Thank you all.
Thank you, Dr. Vidyalakshmi, for that thoughtful vote of thanks. With that, we come to the conclusion of today's session. On behalf of the IHMA National Women's Wing, sincere gratitude to our speaker, Dr. Shalini, and thanks to all the participants for your valuable time and participation. We look forward to meeting you all again in our next session, which will be held next Tuesday, 18th of November, by another eminent speaker, Dr. Kushali Gambhir, on the topics adolescence to 40 years and menopause and beyond. So as I wrap up the session, wishing everyone a pleasant evening ahead. Thank you so much. Thank you.